Good afternoon, everyone, and for some of you, good morning. Thank you for joining us today. My name is Jessica Porras, and I'm the Senior Manager at CAQH Core. Welcome to our webinar with X12, introducing the 278 Transaction Standard and Operating Rules. Next slide. I'd like to mention a few logistical items. If you'd like to download the slides right now and follow along with us, you can go to the handouts part of the dashboard that you see there on the right-hand side and download those. You can also follow along with us on video. We will send you the recording as well as the slides after this webinar, so you'll be able to access those slides later on if you wish. In addition, you can ask questions at any time during the webinar. And we will have dedicated time throughout the webinar to take your questions. Next slide. This is what we'll be covering with you all today. We'll have speakers from X12 talking about the 278 transaction standards. Then we'll have speakers from CAQH Core talking about the prior authorization operating rules. And then we'll have a dialogue with our speakers on ROI, followed by Q&A. Next slide. I'd like to thank all of our speakers for being with us here today. We look forward to hearing all of your presentations throughout the webinar. Next slide. With that, I'd like to introduce Bruce Belsey from Aetna for being here with us today. Take it away, Bruce.
Oh, thank you, Jessica. Yes, we're going to be talking about the introduction to the 278 standard today. So next slide. This presentation is for informational purposes only, and it's not intended to represent any type of legal advice. The content is point-in-time information and always subject to revisions. If you have any questions at all about the information that's to be shared during this presentation, please send them to info@x12.org. And please visit www.x12.org for any additional details about X12. Next slide, please. X12 was established by ANSI about 35 years ago. And what we do is we develop and establish EDI transaction standards and technical reports, as well as XML schemas, which actually drive business processes throughout the world. The membership at X12 is just so diverse. We have providers and technologists, business experts across all different types of industries, which range from healthcare, transportation, finance, logistics, supply chain management, and as well as with other industries. For more information about X12, please visit us and how to become a member at www.x12.org. Next slide, please. The agenda that we're going to cover today is we're going to talk about the purpose and scope of the 278, along with its benefits and the uses, and actually who uses the 278. And then we'll give a high-level overview of the 3 different type of 278 TR3 implementation guides and the business processes that they actually support. We'll give an example of a 278 authorization workflow process, and then we'll finish up with just talking about other unique data supported that's actually within the 278, that it supports the UN review and or the provider's ability to better describe what they're trying to request. Next slide, please. The purpose and scope of the 278 TR3 is really to provide a standardized data requirements and content for all the users of the 278. And even though we're going to talk about 3 different TR3 implementation guides, they all have their own special business purpose. But if you look at the actually structure within the 278s themselves, they're pretty much all the same. You know, you're going to have one section that has the details of who's actually making the request or the submitter of the notification. And then you're going to have segments and details that describe the member, as well as segments that are specific to who's performing the services. And then there's data elements of where and when the services are to be performed, and also the approval status. I mean, is that transaction or has that event been approved? And also why the services are needed by including a diagnosis code and or other unique data to support the reasons for the request itself. These implementation guides are really designed to assist those who send and receive authorizations, notifications, and inquiries, all by using the same standard 278 format. Next slide, please. Let's talk about the benefits of 278. Basically, the 278 EDI exchanges automate the function of entering authorization data directly into the database and or systems used to assist healthcare workflows. Now, I know this first bullet is really talking about, hey, see how it benefits a UMO, for example, and it does. If you're looking at it when you're trying to take these phone calls and entering in authorization requests and everything. But you can also look at the flip side of that as well. Of how does EDI actually assist, a provider? I mean, if there were more ability for a provider where something could be scraped from their practice management system, for example, and create the 278 and send it in that fashion versus having to do a telephonic or manual or paper referrals or paper authorizations, that would be a benefit for the providers as well as the UMOs. By doing it electronically, you really do eliminate or reduce any telephonic requests and manual entry. And by doing this, you offer an opportunity to reduce FTEs. And I'm not saying reduce the FTEs so you can eliminate jobs, but instead of doing that, you could take those FTEs and actually apply them to do and to concentrate more on patient care versus the actual administrative efforts, to handle the authorization workflow. EDI also improves the accuracy of requests because almost all the data is codified. You have diagnosis codes, you have procedure codes, you have MPIs for providers, and it's just a benefit, and you're not working with free-form text. And then, of course, the opportunity to facilitate a faster turnaround time in the decision. Because responses are really within seconds when you're using EDI. And if you even look at the CAQH core operating rules, for example, the end-to-end life cycle of an authorization transaction is 20 seconds or less. And that's end-to-end. But if you look at the time that it actually takes you to pick up the telephone, even dial the number, and even get to a live person, the EDI transaction can be done and gone by then. And then lastly, the electronic option is available for all the provider entities that are actually involved with the patient's care. It's not just for the PCPs, it's just not for the UMOs, but any of the entities that are in taking care of the patient also are allowed to do it electronically as well. Next slide, please. So as I said earlier, there's the three different uses of the 278 TR3 implementation guides. And for the most part, when people talk about a 278, they always think of, and there only is, the authorization process. And this is where you're talking about your pre-cert requests or your authorization requests, where you require review, and then you wait for an approval before the services begin to take place. But that is just one 278 TR3 implementation guide. There's actually three that we support in Workgroup 10. So the second one is the inquiry transaction, which actually is used to view the patient's history. And that's very important, especially for facilities and or specialists. When it comes to actually, one, you have to check to see if the patient's coming to you, if that authorization is even approved or not, which is also helpful in scheduling or verify what services actually need to be performed and the time frame in which they need to be completed. The third TR3 implementation guide has to do with the notification, and that is nothing more than exchange of information between one healthcare entity and the other, and they could be used for both delegated arrangements or non-delegated. Next slide, please. So who actually uses the 278 today? I know we have some bullets here, but if you think of the life cycle of a patient care and all the different entities that are out there to support the patient care, the 278 would support any one of those entities. You have not only who's doing the patient care, and you think of vendors and clearinghouses, yes, they're also in support of the vendor or of the patient care because they're the ones that are sending that information to and from the providers and the payers, etc. So you have the vendors and clearinghouses using 278s, payers, UMOs, labs, physician practices, facilities, home health care, ambulance transport, behavioral health, and you can go on and on and on with different bullets of who actually is entitled or actually uses the 278 today. Next slide, please. When we're talking about the 278 TR3 implementation guides and their business processes, I kind of started talking about it at a high level, but when we talk about the authorization transaction, we're really talking about the X217. And this is your authorization and referral transaction. And this is the one that's actually the technical report that's adopted under HIPAA. And when you use this authorization or referral transaction, it's utilized for you to describe anything that requires some type of utilization review. And you can do that by either by just using a procedure code. Because a procedure code or a service type can explain or describe the type of service that's requiring some type of authorization process. We also have the TR3, the X215, which is our inquiry transaction. And this actually provides the ability for whoever's doing the patient care to look at the status of that request. Now, the inquiry transaction itself is very unique, and there's different ways to use it. One, you could submit an inquiry transaction and include in that request the actual authorization number that was returned in the response. When you use an inquiry transaction in that fashion, then when you are searching for the event history for that member, then you only want the event for that event number that you sent in your request. And so that's all you're going to get is the details of that event, that specific event. But the inquiry is actually built a little bit more robust, where you can also do an inquiry on multiple events within the provider's database. In those types of scenarios, when you submit an inquiry transaction, the requesting provider wants to look at as many events as possible, for example, then it's up to the payer to describe or send back the events that they want. For example, let's say it's a cardiologist that wants to refer or wants the inquiry on the patient's event history. In that situation, let's say the payer has 10 events for that member, and the inquiry comes in and the requesting provider's MPI equals XYZ. Well, then the payer's only going to send back maybe 2 out of the 10 events are associated to that cardiologist, and that's all they're going to get back in that inquiry response. And that's because that cardiologist shouldn't be able to see, the patient's event history for behavioral health or the urology or whatever the case might be. So it really is up to the payer, kind of protect the patient's PHI and only allow the inquiry events that should be returned in the inquiry response. And as a side note, for what I've seen in the past for our inquiry transactions that we utilize, for every authorization request that comes in the door, you probably see 3 to 5 inquiry transactions against that authorization request. The first one might be, waiting to see, hey, is that event still pending or is it now approved? And then the other flip side of that is it could be a specialist or the facility, inquiring on that event history, one, to see if it's approved or not, but also to see, what is the event for? What are they authorized to do? What procedure codes, etc. So the volume of your inquiry transaction is usually 3 times more than what your request and response is. And then the third TR3 implementation guide, supports the notification and acknowledgement, which is the X216. And there's such a wide variety of uses for the X216 because it's nothing more than a transfer of event history or event data from one entity to the other. And there's no restrictions on who can send a notification and who can receive it. So it's really whatever type of business process or workflow that you're trying to prevent from happening. It's however creative that you want to use it. I mean, if you look at it from a payer to a third-party delegate, for example. Let's say a payer delegates their high-tech radiology to a third party. You would use the notification to accept all those events that were approved or denied by that third-party delegate, and load it into your system, either to support a downstream claims payments process, or maybe a disease management program, or whatever the case might be. But that's just a way a notification could be used by a UMO. But if you look at it from a provider perspective, it also can be used for numerous ways. I am not sure from a PCP to a specialist perspective. I mean, how does a PCP notify a specialist today that they're sending John Doe over for these procedure codes, for this many visits, for this diagnosis code? Do they do it electronically, or do they do it telephonically? But this notification process offers that ability to do it electronically versus having other processes to do that. That way it frees up your staff to concentrate more on patient care, and you're not spending so much time on the telephone. Next slide, please. This slide here was basically to represent one of the authorization workflow processes to talk about appended response, and then the new CAQH core operating rule of requesting additional information for appended requests. But this is just one flavor of a 278 authorization workflow process. Now, the utopia of an authorization response, of course, is to return a certified and total response. And that's what the providers want. That's what the facilities want. That really is kind of up to the payer or the UMO of how they create their systems and develop their systems. But sending back a certified and total response should be just as easy as sending back a appended response or a no action required, for example. Let's say your system is set up to a request comes in with a diagnosis code of appendicitis. And then in that same request, there is a request to do an appendectomy, and they're asking for a 1 or 2 day length of stay. Most chances, or most of the time, UMO is not going to spend the time and effort to do any type of utilization review for that type of scenario. And based on the M&R guidelines, for that specific procedure code, it's a 2 day length of stay. So in those cases, they're going to send back a certified and total response. And then if there's any follow-up, that can be done through the concurrent review process, etc. But that's just the utopia, or the best way to probably do a 278 authorization workflow process. But there's a lot of times where you also have to pen the response. And to be honest, the 278 also supports, the ability to return a no pre-cert required transaction as well. But what we really want to kind of showcase today, is the CAQH core operating rule, in which a provider submits a request for an authorization, and then when it hits the payer's system, they have to return a pended response. And with that pended response, it's going to include a request for additional information. And there's different ways to request additional information, but what we're showing on this slide here is the process of providing a LOINC value to actually a codified way to express the type of data that's really needed to complete the review. Now, if by chance your system's not set up at that time to automatically return those LOINC values in your pended response, then the new rule is basically saying, hey, if you can't do it initially, then you're allowed to do it, or you have to do it within 2 business days after that initial request to actually send that information of what you actually need. So that's part of the new rules, but also included in that pended response is the ability to return the actual attachment control number along with those LOINC values as part of that initial pending response. And when you do that, the provider should get that information. They're going to gather up the data that's needed or that you had requested using the LOINC values, and then they should be sending that information back to the payer in the 275 that supports the actual healthcare service review. And within that 275, it's also going to include that attachment control number that you sent in the pending response. And that's very, very important, because that way, when the payer is receiving this additional information on a total separate day, a different process, that they have the ability to mirror that additional information that was received and that you're trying to ingest and actually link it to that pending event that's in your database. And so that's why it's so very important to use that attachment control number in your response. And then it's just as important to make sure that you include that attachment control number when you're sending the data to support that review back to the payer. And once the payer has received all the additional information, then they have 2 business days to send that final response via EDI. So that's kind of one of the life cycles of the new pending CAQH core operating rules that I just wanted to present. But there's many, many different types of utilization workflow processes, but this is one showcase for the pending response. Next slide, please. There's really many other unique data that supports or assists with the review and or the provider's ability to describe the requests when they're sending their information to the payers or UMOs. There's different tracking numbers, for example, within the 278 that are unique to either at an event level or service level. And those tracking numbers, when we're talking about the TRNs, for example, they're used to track, through the whole life cycle from the time that the 278 is created all the way through the life cycle to the time that the 278 actually is returned back to that sending entity. And those tracking numbers are basically just to keep everything in sync within, different systems. There's also different numbers that are associated in the 278, like the authorization number, or the administrative numbers, or as I just described, the attachment control numbers as well. So there's different segments that you use these different numbers for, just to kind of keep everything straight. In addition to these numbers, we also have different dates that are supported in the 278. You have your admission dates and your discharge dates, accident dates, and also, either event or service dates. So it's just used to better describe what's needed as part of those requests or the notifications and or the inquiries. So tons of date segments to describe what you needed. Another very important bullet or functionality of the 278 is the ability to report if this request coming in the door is an initial request or is it an update. I know if you think about your workflow processes, how many times do you spend administrative efforts just to call the payer to say, hey, we're changing the admission date, or I want to add a diagnosis code to this event, or I want to add a diagnosis code, or I want to increase the visits to 5 more visits for the same time frame, or you want to change a date. The 278 supports that process. Not only the ability to say, hey, this is the first time I'm requesting this, but once it's in the door and in the system, and you need to change where that patient's going, or maybe that you want to change the facility that they're going, that EDI update functionality exists in the 278. And if you incorporate it into your workflow, then you can, hopefully eliminate a lot of those mundane telephone calls, just to add something or just to change something. So it's a very important functionality of the 278 that is supported. But I just don't see it, utilized that often today. The 278 also offers a wide variety to just describe complex delivery patterns. yes, you do have the ability to say visits 1, units 3, or whatever the case might be, but there are some times where you need to express, I need this nurse to visit for 3 times a week for 4 weeks, for example, or other, maybe it's a drug request or whatever the case might be. The HSD segment offers that ability to communicate those types of complex delivery patterns for the patient's care. There's also the ability to describe the specialty of the healthcare entity, as well as there's address information that you can use to let us know about the provider. And then there's also address information for like the ambulance pickup and drop-off locations, for those types of reviews that require, that type of information. If you look at, even for an ambulance request, it's a big difference if the pickup location is in Tulsa and the drop-off is at the Mayo Clinic, in Rochester. That makes a big difference versus an ambulance request that's going from a nursing home to across town, to the hospital for whatever the case might be, for the patient's care that need to drop off. The other one is the 278 does support dental and tooth segments for any type of dental requests. There's special segments just for those types of requests. And I know it probably doesn't get utilized as much, as what the claims use for the dental and tooth segments, or requests, but the 278 supports that. The same thing with drug requests. In the SV loops, there's qualifiers to say, hey, if this is an NDC, whatever the case might be. And I've heard in the past that the 278 doesn't support drug requests, but it does. And even with the new version of the 278 coming down the road in the 7030, there's a new drug segment altogether that can be used. And also, there's placeholders for the link. Remember, we talked about just recently about the ability to send or return a link in that pending response. Well, there's different ways you can do that. You can put the link value at an event level and actually tag it to a diagnosis code, at the event level if you wish. But if you have like different services, let's say you have 3 different procedure codes that you're trying to get authorized, and the event is actually pending and you're requiring medical review, well, you could send link values that are also offered at each HLSS loop. So in those types of responses, you could put a link value at the event level and tie it to a diagnosis code, or at each HLSS loop, you could have, for procedure code 1, you might have just one link value that you need to request on. And maybe for the second or third procedure codes, you might have 2 or 3 link codes. So the 278 offers that flexibility to put those link values either at an event level or service level, and up to 12 if you needed per procedure code. And then we also allow the ability for freeform text. Is it desirable to use freeform text? No, not really, because we would like everything to be codified, but not everything can be codified. It's just as simple as that. And offering that ability to have that freeform text or message segment at the event level and or each service level is beneficial, when the provider needs to describe something that just can't be codified. And so that ability is there, for that process to take place. I mean, I could probably put in another 20 different bullets on the different unique data that is supported in the 278, but I'm just kind of stopping here at the high levels of things that we do know to be true and the 278 does support. Next slide, please. So what can you do to become an X12 member? Please do. If you're not an X12 member, I think you should really consider being one and also participating in the X12 standing meetings. It's unbelievable at the amount of talent and expertise that show up to these meetings, and actually the collaboration that happens during these meetings to guide how we manage and create and change and guide all of our implementation guides. this is where the rubber meets the road. And when we're making our changes, we all get together, and this is what we do. We try to make these TR3 implementation guides usable for everyone. And it's also so important that when we have a public review period, that you spend the time and the energy to actually look at these changes and making sure that, hey, are they working the way that they need to be working? And if they're not, please submit requests so we can make the changes to actually support your needs. And we do this every single, because this is always an evolving process to make the guides usable for everyone in the industry, not just for the payers, not just for the trading partners, not just for the providers, but it's everyone that's in the whole life cycle of the patient care. So if it's not meeting your needs, please submit your requests so we can change it and see if we can change it and make it so its functionality works for everyone. Next slide, please. I would like to thank you all for offering me the ability just to let you know what I know about the 278. If you have any questions or feedback regarding what was presented today, please post them at the www.x12.org. And for any more information about X12, please visit us at www.x12.org. And please follow us on social media via Twitter or LinkedIn. Next slide, please. And Jessica, I'm going to turn it back to you.
Thank you, Bruce. If we could go back to slide 17, I wanted to thank you, Bruce. Your presentation was so clear and thorough. And I also wanted to pause because we did get an audience question, and I thought we should just address it now rather than waiting for the Q&A portion. And I think I also welcome Megan and Luann to chime in if you so wish. We received a question, which is, why aren't there solutions in the practice management system that use the 278? Would any of you like to respond to that?
Well, sure. I mean, I'm not sure why they're not. I mean, what I feel is they should be, is because basically scraping something from a practice management system, I believe all the information's there, of what's needed to actually populate the 278. So it's nothing more than, taking that extra step to develop that process. And I'm sure from a provider's perspective, they would welcome that to rather just select something whenever they say, hey, we need to do a referral for Mr. Jones, that the practice management system could create that 278, and so that way it's an electronic process from the provider all the way to the payer and then all the way back again. And I'm not sure why there's not more tools that actually do that type of process, but I think to eliminate all the administrative efforts that do happen, I think that's a very valuable tool that needs to be completed to at least assist with the administrative efforts that does occur through the UM review process.
Yeah, Bruce, that's a good point. And this is Luann Hetherington. One of the things that we've talked about in the past is that when the HIPAA transactions came about, the focus in the very beginning was on the claim and the claim payment and status. And those are the things that got the attention in the beginning with the practice management systems. That's your bread and butter. And the 278 kind of sat back and wasn't as important at that time. And I don't think once your different ways, mechanisms that we do today with portals came about, I think the practice managements might have lost a little bit of sight of what they could be doing with that 278. I think we just need to entice them to get started with it again. But I think that is part of the reason why the practice management systems, many of them don't have it today.
That's a really good perspective. Thank you so much for your feedback. And now I'd like to go on to our next presentation. I'd like to introduce our next speaker, April Todd, who's a SVP for CAQH Core and Exploration. Welcome, April.
Thanks, Jessica, and good afternoon, everyone. If we could move on to the next slide. I want to just give a very brief overview about what CAQH Core does, and specifically what operating rules are as background. And then Bob Bowman will go into some detail around our new operating rules and how they help to support the standards and the workflow process in particular that Bruce had just spoken about. So CAQH Core, we are a nonprofit multi-stakeholder organization, and our mission is to drive the creation and adoption of operating rules, which really are common business understanding to support standards, and through doing that, accelerate interoperability and help to align administrative and clinical activities. We do this by being a facilitator and bringing the industry together to help work on these operating rules to support the standards. So when we bring people together, we are bringing people together that represent a very broad spectrum of the industry. They represent health plans covering over 75% of covered lives in the US, a variety of providers and provider associations, vendors, including clearinghouses, EMR vendors, and others, as well as government entities, and those representing the SDOs, such as X12 from today, HL7, NACHA, and CPDP, as well as WEDI. And so if we can go to the next slide, I'll give an example of what we mean by an operating rule. So an operating rule, as I mentioned before, are the business rules and guidelines for electronic exchange using the transactions. And I have two examples here to help provide a little bit of background in terms of what we mean. So first, from the healthcare perspective, I think many people are very familiar with the 270 and the 271 eligibility request and response transaction. This is the most widely used transaction in the industry, and it is a standard that is required under HIPAA for plans and providers to use to exchange eligibility information. So one of the very first operating rules that CORE developed was an operating rule to support use of this transaction. And actually, following adoption of this operating rule, the volume of the use of this transaction increased significantly and became much more electronic than it originally was. So under this operating rule, there are requirements for what information is exchanged, including copay and deductible information, and that it must be done in real time. So it takes the what can be done under the standard, which is very broad, and specifies very specific information that must be exchanged, how it must be exchanged, and under what timeframes. So very similarly, I would reference operating rules that exist in the finance industry. So this doesn't just exist for healthcare, but for finance as well. So in the financial industry, financial organizations are required to use standards under X9 in all ATM transactions. And there are operating rules actually put out by NACHA that are followed by all the banks and the Federal Reserve that actually allow you to be able to go to an ATM all across the world and be able to pull money out of your account. Those types of business operating rules allow the industry to function much more effectively. So the last thing I want to specify about operating rules, just to set some boundaries around what operating rules do, is to say what they don't do. So operating rules do not specify whether or how a health plan or provider structures a business process. For example, related to prior authorization, operating rules are not intended to specify when or how a prior authorization is used by a health plan. For what services, for example, a prior authorization is needed. However, where operating rules do come in is that if a prior authorization is needed or used, that the rules would specify how the information regarding the transaction is electronically exchanged. So hopefully that provides some helpful background around operating rules and how it helps to support the standards in encouraging electronic adoption throughout the industry. Can we go to the next slide, please? So specifically related to prior authorization, wanted to lay a brief foundation for Bob, who will be coming up here shortly, to talk about the different rules that we have that are in play, and also talk about a transition that that we are currently making here in Q2 of 2020. So Bob is going to talk through essentially three different sets of operating rules. Bob is going to talk through our prior authorization infrastructure operating rule. And so this operating rule has most recently been updated to include changes to response times. Bob will also talk about our prior authorization data content rule and components that are included in that and how that applies to our web portal rule. And then lastly, talk about connectivity and how connectivity applies to prior authorization as well. And the main change that we are doing in Q2 is we are moving from what people are probably very familiar with as a phased-based approach. So we had these rules included in phase 4 and phase 5, and we are transitioning them to just be rule sets that are based on prior authorization and referrals. We are doing this to make the operating rules, one, both easier to understand for the industry and also easier to update over time. It is challenging for us to think about a phase 20 of operating rules, and so we are aligning them to their business process. So with that in mind, can we move to the next slide, please? So as we lead into talking about the operating rules, I wanted to highlight the reason why at CAQH Core we have been focusing on prior authorization. One of the reasons we are focusing on this is that as compared to all of the other transactions that are done within the industry, prior authorization is very much lagging in terms of how it is conducted from an electronic perspective. In the most recent CAQH index report from 2019, we tracked that only 13% of prior authorization transactions are done electronically using the HIPAA standard, and that the vast majority of the other prior authorization transactions are done either through web portals or conducted through mail, fax, phone, and email. And so there really is a need in the industry to find ways to encourage more electronic adoption of this transaction to reduce provider burden. So you can go to the next slide. And so in developing the operating rules that Bob will go through here in a minute, we really engaged with the industry to try to understand why the adoption of the 278 was so low. And what you'll see here are some of the main reasons that we have heard from industry around why this is so low. And during this process, we engaged with over 100 different industry organizations to gather information for this process. And those organizations are also involved in the creation of these operating rules that you'll soon hear about. So the first barrier that we heard was that there really is a lack of consistency in the use of the data content across the industry and what can be used in the 278. And so there really was really just a lack of standardization of use of data content. And so what you'll, in response to this barrier, you will see the data content rules that have been worked on by CAQH Core participants to try to address this barrier. Both second and third is there is a barrier to being able to communicate clinical information. And this comes in two different ways. One is that there is no federally mandated attachment standard right now to communicate clinical documentation. So most of that is communicated through manual means such as phone, fax, email. And there's a lack of integration between clinical and administrative systems to be able to share that clinical information. So these operating rules do not specifically address these two barriers, but CAQH Core is in the process of soon working with our participating organizations on operating rules to help support the exchange of attachments or clinical documentation. And one of those use cases is related to prior authorization. Next, there is a limited availability of vendor products that support the 278 and support electronic use or exchange of information for prior authorization. We have done surveys in the past that have shown that there's only 12% of vendors are supporting this transaction, and that is compared to very high levels, around 90% of all of the other transactions for which vendors are supporting. There's also just a lack of understanding of the breadth of the information available in the 278, and hopefully from the presentation from Bruce today, we could help to expand that understanding of what can be done with the 278, particularly among providers. And then lastly, just varying levels of maturity along the standards and technology adoption curve. And what we're trying to do with the operating rules is really help to meet people where they are. We know some people are very advanced in trying to work on things related to fire and other new technologies, where others are nowhere near that place and are really trying to get out of using paper and fax and email. And so we're trying to create a middle ground where we think people can come together and move forward here. And then lastly, I would also just mention that there are some state requirements that vary quite a bit across the US in terms of their requirements for prior authorization. Some of them have requirements for manual intervention, but there's also been a lot of variability in the requirements for timeframe response for prior authorization. And that was one of the reasons for also focusing on trying to get to a national standardized response time requirement as well, which Bob will also talk about here over the next few slides. And so without further ado, I'll hand it over to Bob and have him walk through some of the details of our rules.
Bob, we can't hear you if you're on mute.
Sorry, I think there was a problem there. Can you hear me now? Just confirm.
Yep, thank you.
Great. Apologies. Thank you, April, for the introduction. And as April and Bruce mentioned, what we are seeing through the industry is there's been a lack of adoption for the standard and a heavy reliance on manual processes and IVR and web portals. So how can we, as an organization, with our mission and vision, as April mentioned, to address that lack of adoption and meeting the industry where they're at and leading a kind of a phased approach without phases to get them to adopt standards and make things more electronic and more efficient along the way. So over the last couple of years, we've been working on sets of operating rules for the 278 transaction. Also considering things that are still, the industry is still working on, like again, as April mentioned, REST or APIs or FHIR, right? There's lots of variability within the technology, but many of the business processes for the PA are the same for a provider, whether they're submitting it to one health plan or another health plan, and the same backend process for the health plan as well. So the consistency that the operating rules can bring to those different pieces of the process can really help entities build applications, close automation gaps, and really help patients receive the care that they need. If we go to the next slide, we'll actually get into some of the detail related to the actual operating rules themselves, beginning with the infrastructure rule on slide 25. Again, we do have very specific requirements around batch or real-time processing. We have very specific requirements for connectivity and security, right? We have to make sure that the information, as Bruce mentioned, the PHI that's coming from the provider into the health plan is secure through that transmission. We have to make sure that the health plan can receive it, so there's system availability requirements. We have to make sure that application vendors and clearinghouses can help bridge the gap between the technology and between the provider and the health plan. So there's a companion guide template too, so everyone knows what data is needed and where and how and what those values should be and how they're going to be conducted from one entity to the next. So those companion guide requirements are very important as well. So again, all of the infrastructure requirements allow for really the train track to be laid so that the transaction can move from point A to point B, and those roles and responsibilities, those service level agreements can be hammered out and understood so that everyone knows what's coming, when it's coming, and what date is going to be there, and when to acknowledge and receive a response as well. If we go to the next slide, on slide 26, we do want to highlight a couple of the recent updates that we did to the rule set. And again, April mentioned a couple of these, but in particular, we've set up specific SLAs or response times that are geared towards when a provider submits the inquiry, how long does the health plan have to respond to the provider requesting additional documentation? Again, in that example that Bruce used earlier, requesting that information, they need to be able to submit or send that request within 2 days of receiving the initial inquiry. Again, that allows the health plan to adjudicate the inquiry within their systems. And today we understand that maybe manual, so we have to have them provide time for them to do that, send that request to the provider. The provider has to have time to analyze and process that request as well. Again, we have specific requirements if the transaction is conducted in batch or real time. So 2 days for batch, 20 seconds for real time if this system can automatically generate that response and send it back. Or again, 2 days, again, 2 days for real time if the documentation needs are unknown by the adjudicating system. Again, allows for systems to be built. Those roles and responsibilities, those adjudication requirements can slowly be built and added to over time with the operating roles. So again, this is specific for the request and response. We also have response time requirements, again, a 2 business day response time for that final determination to be returned once a health plan has all of the data that they need. So if health plans received everything they need in the initial inquiry, they can respond within 2 business days for that final determination. Or if there's that back and forth, that dialogue requesting additional information or data, right? Perhaps they need an operative report or progress report or imaging. We'll have time to identify that need, send it to the provider can identify that documentation, remit it back to the health plan, and the final determination can be made. And last but not least, we also have a requirement that health plans may choose to implement with a 15 business day way of notifying the provider that because we did not receive everything that we need, they can close out that transaction. Again, it's a HIPAA transaction that came in, the 278 inquiry, so pushing out a determination that it is being canceled is important so the health plan can actually have a full accounting of an inquiry and a response for every transaction. So again, very important process, ensuring that providers have the understanding of response times related to their inquiries, as well as the responses when they should get those is key to interoperability, really. If we go to the next rule, we also have specific requirements, as I mentioned, around connectivity. Again, very important for security and connectivity. Those requirements are very particular and very specific. It does help simplify the interoperability because we've converged onto a single message envelope as also a single authentication standard. Again, this allows those vendors and clearinghouses and systems that both health plans and providers rely on to be built out, right? Luann mentioned that the incentive to incentivize practice management software vendors or clearinghouses and vendors in this space, making it a simplified process to make those connections and onboard trading partners can really help speed that development of those types of systems. If we can go on to the next slide, on slide 28, April mentioned that we do have some specific requirements around the data content of the 278. I think from Bruce's great presentation earlier, you can see that there's lots of variability within the 278 inquiry. It can support many, many, many use cases, and that can be daunting to a health plan, especially if their back-end systems are not very mature in receiving that wide variety of data. So what we've advocated here with our first pass of the data content rule for the 278 is to build out certain modules or certain systems to help automate that process. So consistent patient identification, specific AAA error codes for certain scenarios, as well as returning service decision reasoning codes to make sure that the provider gets the easiest, most clear messaging back so they can make corrections. They can resolve that pend that has come back from the health plan. It makes it much easier for the provider to implement that business process. And also, we mentioned the LOINC codes as well as the status for the adjudication. All these are really, really important for that messaging back to the provider. We go on to the next slide. We also have some requirements around the web portal. Again, as we mentioned, the industry does rely quite heavily on web portals for the PA process. So we do have operating rules related to this as a way to bridge the gap between and moving forward to a fully automated EDI solution. Again, some of the requirements related to the use of the 278 request response TR3 implementation names. So this is really down and deep into the requirements of the implementation guides and making sure that really that the entire industry starts using the same vocabulary when it comes to identifying a patient or a provider or a health plan, and making sure that we're all using the same vocabulary makes it much easier as we progress to a fully automated system and process. If we can go to the next slide. I do want to highlight that we do have an important prior authorization pilot initiative going on where we are playing matchmaker with different health plans, providers, vendors, and clearinghouses to meet them where they're at. And this is if you're in the middle of implementing a PA process or a solution, we can help come in and help do some measurement studies, help understand your systems, and help bring this to the industry for really for the larger community to understand the ROI that is important for these types of initiatives for people to progress in their systems and then their development of their systems. Not only if you're in the middle of that process, but if it's a brand new implementation as well, we can also take that option and ensure that if you're applying new operating rules or existing operating rules and using the standard, if you're using other standards like HL7 in this process, perhaps to exchange the additional documentation needs for the prior authorization support. Wherever you're at in this process for prior authorization improvement, and many health plans and many providers are looking at ways to do this. CAQH Core can help bring your success stories to the larger industry to help us ensure that we're defining the business case better. We're defining specific use cases that can be applied to a more automated process. So again, if you're interested in any of our PA pilots or being part of that process, please contact us and let us know. And last but not least, I do want to go to the next slide, let you know that our core board is very interested in this topic, and in February of 2020 sent a letter to NCVHS proposing the core prior authorization connectivity operating rule package for recommendation to the secretary. Again, here are the hyperlinks to the 3 rules that we are going to be talking about, and the NCVHS hearing will be scheduled later this year in Washington, D.C. Again, there's 3 main reasons for us promoting this. Obviously, we need to improve automation and the timeliness of the PA process. The connectivity operating rules definitely enhances security and promotes uniformity for all the requirements, again, helping ease the build of systems and applications for this process. And the operating rules also set the stage, really groundwork for building upon them in the future, right? As we continue to converge between administrative and clinical data, we have to have a base or a foundation for the conduct of the transactions and the exchange of the data. And moving forward, we can continue to build on that foundation. I know I went through it pretty quick. We're running close to time. We have a quick polling question. We'll have it up for just 30 seconds. We just want to get an idea of how you currently transmit your prior authorization requests today, and please select all that apply. I know that we want to talk real quickly with our panel about some of the ROI that they have in their own implementations of the transaction with their trading partners and with their provider community. So we'll keep this up for just a few more seconds, and I'll ask Jessica to close that as we move to our last slide for the day. And again, April mentioned through our CAQH index that we studied not only the volumes that come through and how they're transmitted, but we also do a cost savings opportunity checklist as well. So basically, the entire industry can save over $450 million by migrating from a fully manual process to a fully electronic process. And both providers and health plans have this potential for savings. So I'll ask Bruce at Aetna what his perspective is on the return on investment and implementation of a fully automated process. Bruce?
Oh, it's unbelievable because we actually supported all 3 of these TR3 implementation guides, and we just kind of incorporated those 3 different guides into our various different business processes and workflows. And so it does that whole administrative effort where you can have it done electronically versus telephonically or paper is incredible. And then you can use that same staff for, like we said, to concentrate on patient care versus these administrative efforts just to get information into your system.
Great, thank you, Bruce. And unfortunately, we ran out of time, and we understand that there may be some questions that have come in from our participants today. We will be addressing those as we can through future education events and through our FAQs, and maybe also some individual follow-up as well as needed. So again, I'll hand the call over to Jessica just to close us out, but I thank you again for joining us, and stay safe out there. Thank you.
I want to thank all of our speakers and also our audience for joining us here today, and we look forward to continuing to collaborate with the X12 on future webinars. Hope everybody has a great afternoon. Thank you. Bye-bye.